Okay, very good afternoon to all of you. And on behalf of the Academic Committee of Sri Lanka Association of Urological Surgeons, I would very warmly welcome all of you to the second season of our Uromet program. So this is urology monthly education for the trainees. I think as a start, we are starting with the renal cancer segment today. So we have actually four trainees who are in different parts of their local training. And we have acting urological surgeon also joining as a session of journal articles. Myself and Hilary will be moderating today's discussion, and we have eminent experts on the subject, Dr. Anuruddha Begunasekara and Dr. Balasingham Balagobi. So without a further ado, I would like to invite the first speaker, Dr. Mahendra Herath, to speak us through about the renal cell cancer core topics and including the benign tumors of the kidney. Over to you, Mahendra.
So under my presentation, I will discuss the history and classification of renal masses, then radiological evaluation of renal mass. Then under the renal cell cancer, I will discuss the incidence and etiology, then familial renal cell cancer and genetics and pathology, clinical presentation of the renal cell cancer, screening, staging, and prognosis, as well as few benign tumors. In the history, the first nephrectomy was done by Miss Wolcott in 1861. Actually, it was done mistakenly for hepatoma, thinking that it is a hepatoma, but it's a nephrectomy. Then the first planned nephrectomy was done by German surgeon Gustav Simon in 1869. That is for persistent urethral fistula, and after surgery, patient survived with cure of fistula. Then classification of renal masses can be done under the category of malignant, benign, or inflammatory masses, or based on radiological appearance, including simple cyst, complex cyst, or solid masses. I can share some picture of this classification. When it comes to malignant tumors, it may be primary tumors, metastasis tumors, so inversion by adjacent neoplasm. The malignant tumors in the renals first one is the renal cell carcinoma. It may be clear cell cancers, papillary cancers, or chromopop RCC. Then there are urothelium-based cancers, sarcomas, nephroplastic tumors, and carcinoma associated with neuroblastoma. Then there are metastasis and invasion by adjacent neoplasm. Then there are benign renal masses, such as cystic lesions, such as simple cyst, hemorrhagic cyst. Then some solid lesions, such as angiolipoma, oncocytoma, papillary adenoma, etc. Then there are vascular lesions, pseudotumors, and inflammatory masses. Then when we divide the renal mass according to the radiological and pathological basis, one thing is simple cysts, such as benign cyst, parapelvic cyst, and hydronephrosis. Then there are complex cysts, cystic renal cell cancer, hemorrhagic cyst, hyperdense cyst, etc. Then there are fat-containing mass, such as angiolipoma, liposarcoma, lipoma. Then there are strongly enhancing masses such as clear cell RCC, angiomyolipoma, oncocytoma, papillary RCC. Then there are moderately enhancing solid masses, and then multifocal and bilateral masses. Usually those are familial RCC and maybe metastasis. Sometimes sporadic multifocal RCC, usually papillary RCC or clear cell RCC. Then there are inflammatory masses, infiltrative masses such as lymphoma, high-grade urothelial carcinoma, and sarcomatoid differentiation. Then there are calcified masses such as renal cell cancers, urothelial carcinoma, benign complex cyst. Then we come to radiological evaluation of renal mass. The radiological evaluation remains the stronger predictor of malignancy and metastatic potential of the renal mass. And usually multi-phase cross-sectional imaging provide the most accurate characterization of renal mass while assessing for locally advanced features and intra-abdominal metastasis. Usually The most widely used imaging modality is the CT and MRI, but ultrasound scan as well as contrast enhanced ultrasound are possible options. Dedicated triple phase renal CT remain the most important imaging modality in renal mass assessment. When you come to triple phase CT, the enhancement greater than 15 to 20 house field unit is indicative of RCC, although this does not preclude benign pathology. And solid masses with negative attenuation, that is minus 20 house field unit, indicate of fat and diagnosis of angiomyolipoma. If EGFR is less than 45, need pre-procedure hydration before contrast. And if severe kidney disease, better to avoid contrast. Then you come to MRI with gadolinium-based contrast. The enhancement more than 20% suggestive of, again, RCC. Then the MRI particularly helpful in masses less than 2 centimeters and defining extent of disease in locally advanced renal cell cancer. And with the MRI, there is a nephrogenic systemic fibrosis risk. And usually the risk is high in patient who is on dialysis and CKD stage 4 and 5, then significant acute kidney injury, multiple MRI with contrast. So MRI is used with gadolinium, only the GFR is more than 30. Then you come to ultrasound scan. It is usually non-invasive and inexpensive investigation and can differentiate cystic from solid masses. And there are strict ultrasound criteria for simple cysts, such as smooth wall, round or oval shape, no internal echoes, strong acoustic shadow posteriorly. In the ultrasound, if there is no strict criteria for cyst, it should be evaluated in multiphasic cross-sectional image. Then contrast enhanced ultrasound scan. It uses microbubbles and may play important role in CKD patient in future. This is a summary of my discussion. And if you detect renal mass, first you have to think whether it's a simple cyst or complex cyst. If it is a simple cyst and with strict cyst criteria, you can observe unless patient is symptomatic. Then if it is complex cyst or solid mass, then you have to think about whether this patient is allergic to contrast or not. If there's a significant contrast allergy, you can do MRI with or without gadolinium. Then if there is a significant contrast allergy, you have to assess the GFR as this. If it is GFR more than 45, you can do the dedicated renal CT with or without contrast, or MRI with or without gadolinium. If GFR is less than 30, you can do non-contrast CT or MRI without gadolinium, otherwise ultrasound or contrast enhanced ultrasound. Then we come to assessment of the tumor complexity. Assessment of tumor complexity uses in selecting nephron sparing surgery versus radical nephrectomy. Then we have to surgical laparoscopy, whether we can do it open or minimally invasive, and assessing the risk of complication after surgery. The emerging data suggests that increasing complexity may also correlate with the risk of malignancy and aggressive histology. There are a few scoring systems which we can use to assess the tumor complexity. One is renal nephrometric score and Padua score and C index. In renal nephrometric score, you use radius, endophytic versus exophytic, and nearness to the collecting system, and anterior posterior location, and location relative to the polar lines. And Padua score use preoperative aspect and dimension used for anatomical classification. Then C index is the it measures the centrality index. It assesses the tumor center as nearness to the kidney center and the nearness to the tumor center it assess. Then you come to evaluation of the cystic renal lesion. Risk of malignancy increases cyst complexity. The cyst complexity is defined by wall of the lesion, whether thickness and the contour of the wall, and septa, the number of the septa, thickness and contour of the septa. Then calcification, amount, character, and location of the calcification. Then margin of the lesion, presence of the solid component. Usually Bosniak classification is used to assess the renal cyst, and it is CT-based classification. This is classification of renal cyst, Bosniak classification. There are 5 components. The Bosniak type 1 is simple cyst, which does not need any surveillance. Then Bosniak type 2, again, there's a minimal risk of malignancy and surveillance is not necessary. Then there is a 2F, there's a 3 to 5% or 5 to 10% risk of malignancy, and this need periodic surveillance. And Bosniak type 3 and 4 need surgical excision as there is a high risk of malignancy. Then renal cell carcinoma. The incidence is, it account for 2 to 3% of all adult malignancies, and male to female ratio is 1.9 to 1. Then typical age of presentation is 50 to 75 years. Then majority are sporadic, but 4 to 6% are familial. And in childhood, renal cell carcinoma is uncommon and account only 1 to 6% of renal tumors. 90% of renal tumors in childhood are Wilms and nephroblastoma. The mean age is 8 to 9 years with boys to girl ratio 1:1 ratio. And in the childhood, renal cell carcinoma tend to be symptomatic, locally advanced, and high grade and unfavorable histologies. Because of that, aggressive surgical approach with formal lymphadenectomy is recommended in childhood renal cell cancers. The etiology, the stronger risk factor for renal cell cancer is smoking. Then other etiology are the obesity. And in the obesity, there is a called obesity paradox. Here, even though patient is having high BMI, they are prone to get more renal cell cancer, but when you have the high BMI, the tumor is low stage. That is called obesity paradox. Then hypertension, NSAIDs, retroperitoneal radiation, end-stage kidney disease, and attend the familial renal cell cancer and the molecular genetics. Von Hippel-Lindau disease, von Hippel-Lindau gene and genetics of clear cell renal cell cancer. It's a familial type of clear cell renal cell cancer, and in the autosomal dominant, and in VHL disease include clear cell renal cell cancer, pheochromocytoma, retinal angioma, hemangioblastoma in cerebellum, brainstem or spinal cord, renal and pancreatic cyst, inner ear tumors, neuroendocrine tumors of the pancreas. These all tumors are highly vascular, and RCC develop in about 50%, and it occurs in very early age, usually 4 to 5 decades, and usually those are bilateral and multifocal. And when described on the VHL gene, it's in the chromosome tree, and it's a tumor suppressor gene. And VHL gene is responsible for the both sporadic and familial clear cell renal cell cancer. And VHL gene produce VHL protein. This VHL protein target hypoxia inducible factor A alpha, 1 alpha, and 2 alpha for ubiquinone mediated degradation. So in VHL, in the inactivation of or mutation of the VHL protein lead to accumulation of hypoxia induced factor, mostly 2 alpha, which cause upregulation of lot of tumorigenesis factors such as vascular endothelial growth factor, platelet derived growth factor, glucose transporter 1, etc. So other genes other than VHL gene, there are few genes involved in sporadic clear cell renal cancer. One is BAP1, BPRM1, then SCTD2. Both are involved in more than 90% of sporadic clear cell cancer. And those are located in chromosome tree and involved in chromatin remodeling and histone methylation. BAP1 in sporadic clear cell cancer is associated with very poor prognosis than VHL gene. Then hereditary papillary renal carcinoma syndrome. It's again autosomal dominant condition, and there's a multiple and bilateral type 1 papillary RCC. And compared to the von Hippel-Lindau disease, there are no tumors in other organ. And HPR is due to activation of proto-oncogene. called Uromet, and this is situated in the chromosome 7. And tumors in HPRC is less aggressive than sporadic counterpart. Then you come to hereditary leiomyomatosis and RCC syndrome. It's again autosomal dominant condition, and there's a occurrence of type 2 papillary renal cell cancer and cutaneous and uterine leiomyoma. The mean age of presentation is 40 years, and only 15 to 20% develop RCC. But all the female with this HLRCC syndrome develop cutaneous leiomyoma and uterine fibroid. And usually, compared to the other hereditary disorders, the HLRCC, RCC are unilateral and solitary, but they are more aggressive than other familial RCCs. The gene is the inactivation of tumor suppressor gene fumarate hydrates on chromosome 1. Berthold-Dubé syndrome. This again autosomal dominant disease, and this consists of development of cutaneous fibrofolliculoma, lung cyst, spontaneous pneumothorax, and various type of renal cell cancer such as chromophobe RCC, oncocytoma, hybrid oncocytoma. And the average age of diagnosis is about 50 years. And RCC tend to be bilateral, multifocal, and limited biological aggressiveness. Mutation of tumor suppressor gene which produce folliculin responsible for this syndrome. And when folliculin lost, mTOR signaling pathway activate. Cowden syndrome. This is due to mutation of P10 tumor suppressor gene and has 34% lifetime risk of RCC. And they have 50% risk of female breast cancer and 10% risk of thyroid cancer. And here the RCC is mostly papillary, but clear cell cancer and the chromophobe RCC also reported. Tuberous sclerosis complex. This is again autosomal dominant complex, include various tumors in various organs, angiomyolipoma, Guyan cell astrocytoma, pulmonary lymphangiomyomatosis, cardiac rhabdomyoma, facial angiofibroma. 2 to 3% may be clear cell renal cell cancer as well. And tuberous sclerosis complex is known to cause renal angiomyolipoma. Those are multifocal and bilateral. Often these are large, requiring angioembolization or partial nephrectomy. This is due to mutation of TSC gene, which is situated in the chromosome 9, or TSC2 gene, which is situated in the chromosome 6, which normally downregulate the mTOR pathway. Succinate dehydrogenase RCC. This share features with hereditary leiomyomatosis RCC syndrome. And this is bilateral and multifocal, which early onset, less than 40 years, renal tumors, often alone with pheochromocytoma and the head and neck paragangliomas. This is due to mutation in multiple genes encoding enzyme succinate dehydrogenase of Krebs cycle. These cancer shows Warburg effect, that is, they use aerobic glycolysis by cells and produce lactate. Microphthalmia associated transcription factor associated cancer syndrome. This again germline mutation in MITF confers a greater than 5-fold increased risk of melanoma and RCC in affected patient. MITF regulate hypoxia-induced factor 1 alpha and mutated variant activate hypoxia-induced 1 alpha. Then come to pathology. The most renal cell cancers are round to oval and circumscribed by pseudocapsule, which is composed of parenchyma and fibrous tissue rather than true histologic capsule. Not like upper tract urothelial cancers, most RCCs are not grossly infiltrative, with exception of sarcomatoid variant and collective carcinoma, which has infiltrative growth pattern. All RCCs by definition adenocarcinoma, which are derived from renal tubular epithelial cells. And nuclear features are highly variable and independent prognostic factor, mostly for clear cell renal cancers and papillary renal cell cancers. For the grading, initially used system was Perham system, but now recommended grading system is 4-tier system by WHO. The aggressive local behavior is not uncommon with RCC and expressed in invasion of the renal capsule, renal sinus or collective system, which is is about 20%, but the displacement is more common than the infiltration. The interesting feature is the predilection for involvement of venous system. Usually in 10% cases, and contiguous tumor thrombus can extend into renal vein or may into IVC, and it may extend into even up to right atrium. But some may directly invade the renal vein, which correlate with poor prognosis. Clear cell renal cancer. This accounts 70 to 80% of all renal cell cancers, usually yellow coloring, and it's a highly vascular tumor. In microscopy, they have clear cells, granular or eosinophilic cells, or mixed types, have worse prognosis among the clear renal cell cancers. It's more likely to exhibit venous tumor extension as well. And because this is due to most clear cell cancers have VHL gene mutation, it's more likely to respond to vascular endothelial growth factor targeted therapy, checkpoint inhibitors, or high dose interleukin 2 than other subtypes of RCC, and has better prognosis when it has metastasis. This is a clear cell cancer picture as well as histology slide. Then papillary RCC. This is the second most common tumor. It accounts for about 10 to 15% of renal cell cancer. This is beige to white color in color, and it is spherical boundary and frequent hemorrhages are there. More likely to be hypovascular due to lack of VHL mutation. And this has tendency toward the multicentricity and microscopically basophilic or eosinophilic cells arranged in papillary or tubular configuration. And there are two types. Type 1 is more common, consists of basophilic cells with scanty cytoplasm and occurs in HPCR syndrome as well. Type 2 is a more aggressive with eosinophilic cell and abundant cytoplasm and occurs in HLRCC syndrome. And type 1 have better prognosis than clear cell carcinoma, but type 2 is similar or worse than the clear cell renal cell cancer. This is papillary RCC CT film as well as histology slide. Then chromophobic RCC. This accounts for 3 to 5% of all RCC and derived from the distal convoluted tubules and commonly seen in BHT syndrome, but most cases are sporadic. This has better prognosis for localized chromophobe than this has better prognosis than clear cell carcinoma, but have poor outcome in small subset of patients who have sarcomatous features or metastatic disease. This is chromophobe tumor and the histology slide. Then collecting duct carcinoma. It's again rare renal cell cancer. Most reported cases of collecting duct carcinoma have been high grade, advanced stages, and unresponsive conventional therapies. For that, multimodal therapy, surgery, systemic treatment, as well as radiation appear to improve survival compared with nephrectomy alone for metastatic disease. Renal medullary carcinoma. So again, uncommon variant, exclusively occur in patients with sickle cell trait. And typically, these are young African American in their third decade of life, and many cases are locally advanced or metastatic at diagnosis. Sarcomatoid and rhabdoid differentiation. Sarcomatoid differentiation occur in 1 to 5% of renal cell cancer, and mostly with clear cell cancer, so chromophobe renal cell cancer. This sarcomatoid differentiation are not considered as separate RCC subtype. It has spindle cell histology, positive staining for vimentin, infiltrative growth pattern, aggressive local and metastatic behavior, as well as it has poor prognosis. Then rhabdoid features seen in many subtypes of RCC, but not considered as separate subtype. Poor prognosis. Unclassified RCC. Minority of cases, 1 to 5%. These are poorly differentiated and have aggressive biological behavior and poor prognosis. Then clinical presentation. More than 60%.
In 5 more minutes.
Okay, sir. More than 60% of patients detected incidentally due to the retroperitoneal nature. They are diagnosing incidental finding. And symptoms may be due to tumor growth, hemorrhage, paraneoplastic syndrome, or metastasis. Usually, flank pain is due to hemorrhage and clot obstruction and can occur with locally advanced or invasive disease as well. Classical triad of flank pain, loin masses, and hematuria are now rarely seen. And in the clinical presentation, the indication of advanced disease are weight loss, fever, night sweats. On examination, if somebody is saying palpable cervical node, non-reducing varicocele, bilateral lower limb edema, that again indicate advanced disease. And spontaneous perirenal hemorrhage may be presentation of the renal cell malignancy. And more than 50% of has occult tumor, mostly it's a angiomyolipoma or renal cell cancer. And paraneoplastic syndrome. In about 10 to 20% with patient with renal cell cancer have paraneoplastic syndrome because of their generalized symptoms. It used to call internist tumor. But paraneoplastic syndrome is more common in metastatic RCC. Increased ESR, hypercalcemia, hypertension, polycythemia, Strouper syndrome, that is non-metastatic hepatic dysfunction, may be the features of paraneoplastic syndrome. And Strouper syndrome is a non-metastatic hepatic dysfunction, and this is normalized after nephrectomy in about 60 to 70% of cases. And persistent and recurrent hepatic dysfunction almost always indicative of viable tumor and thus represent poor prognosis. And screening and clinical association. A number of factors make screening for renal cell cancer appealing. Most importantly, RCC remains primarily a surgical disease requiring early diagnosis for cure. But there are so many limiting factors which limit the widespread implementation of screening. One is relative low indication of RCC in general population. Because of multiple limiting factors, screening for RCC must be on well-defined target population. There are few target population you can do the screening. One is patient with end-stage renal disease and patient with known von Hippel-Lindau disease, relative of patient with von Hippel-Lindau disease, relative of patient with other familial form of renal cell carcinoma, patient with tuberous sclerosis, patient with autosomal dominant polycystic kidney disease. But in general population, routine screening is not justified. Staging. Initial staging system was Robin staging, but now recommended staging system is 8th edition of AJCC TNM classification. There are clinical, pathological, and radiological staging. In clinical staging done with history examination and judicial use of investigation. And systemic symptoms such as significant unintended weight loss, cachexia, poor performance status at presentation, palpable mass or lymph node, significant anemia, hypercalcemia, abnormal liver function test, ESR, alkaline phosphatase, LDS suggest advanced disease. And I have shown the TNM classification, but I am not going into detail of TNM classification. Then there's a radiographic staging with high quality abdominal CT and chest X-ray and liver function tests. All the patient can be staged. But if somebody is having abnormal chest X-ray or pulmonary symptom, he should undergo CT chest to assess the chest. And involvement of the ipsilateral adrenal with preoperative involvement of the ipsilateral adrenal can be diagnosed with preoperative CT as well as intraoperative inspection. Enlarged hylo or retroperitoneal lymph node more than 2 cm on CT almost always harbor malignancy. Then prognosis. Prognostic pathological stage is the single most important prognostic factor in RCC. There are adverse factors which predict poor prognosis that can divide under clinical, anatomical, and histological factors. Venous involvement was one thought to be very poor prognostic finding, but report demonstrate patient can be salvaged by aggressive surgical approach as long as cancer otherwise confined the kidney. Direct invasion of the wall of IVs is more important than level of extension of tumor thrombus. These are the adverse prognostic factors of renal cell cancer. There are clinical, anatomical, and histological factors. Then benign renal tumors. First one is oncocytoma. This is the most common benign enhancing renal mass, which cause about 25% of renal mass, less than 3%. And usually unilateral, but about 5% they are bilateral. And these are grossly mahogany brown surface with central scar. Histologically has overlapping features with chromophore renal cell cancer, papillary renal cell cancer, and SDD-RCC. This can present with perirenal fat innervation as well as renal vein innervation. And definitive diagnosis is post-operative, and hypervascularity and central scar suggest diagnosis in CT, but insufficient for definitive diagnosis. Main management is post-surgical observation, but if diagnosis made with biopsy, active surveillance has place. There is a place for biopsy if suspected preoperatively as well. If suspect, but there's uncertainty, nerve sparing surgery is the treatment option. Angiomyolipoma. This composed of dysmorphic blood vessels, smooth muscles, and adipose tissue. It has females predominance and peak age is 4 to 50 K. And tuberous sclerosis complex is the most well-described heritable cause for AML. Usually these are multifocal and bilateral. Mostly diagnosed incidentally with imaging, as presence of macroscopic fat in CT and MRI is diagnostic of AML. On CT, presence of intralesional fat minus 15 to 20 houseful units on non-enzymes in series is diagnostic. Fat poor AML, fat containing RCC, liposarcoma, difficult to diagnose, and MRI will be helpful. Most common cause for spontaneous retroperitoneal hemorrhage is AML, and historically it called Wunderlich syndrome, loin pain, shock, and loin mass, I think. Then management, once diagnosis is made, management should be individualized on sporadic causes, syndromic AML, presence of symptoms, risk of hemorrhage. Risk of hemorrhage is assessed with size of the AML, size of the intralesional aneurysmal size, and the pregnancy status. This is the summary of management of the AML. Thank you.
Right. Thank you. Thank you, Mahin. That's very for that very comprehensive talk on the basics of renal tumors and renal cell carcinoma. Could I ask you? Well, we are actually running out of time, and I want all of you speakers to try and to stick to the allocated time, because we've already started a little late and we wanted to finish it on time. Yeah, just we need to ask a couple of questions from our expert panel also. As a start, Mayan, what do you think about the Bosniak classification, and why do you think it is important, and the importance of management of patients? What sort of inferences you can get from the Bosniak classification?
Bosniak classification is usually according to the CT findings, and we can divide the cyst according to the risk of malignancy. We use cyst, the size of the wall of the cyst, and the presence of calcification, and the posterior acoustic shadow, and presence of solid mass. So it indicates the risk of malignancy with the increasing complexity. So we can decide on the management.
Okay, so if you have Bosniak 2F cyst in your CT IVU, what sort of advice would you give your patient about that finding?
First thing I will tell, there is a 3 to 10% risk of malignancy in this patient, and I will assess the patient with history examination. In the history, I will ask,
is it the Bosniak 2F cyst, has it contained 3 to 10% cancers, or would you advise that this might, around about 10% of patients might develop in the follow-up period a cancer? What is the difference?
think it has 3 to 10% risk of malignancy, sir. Harboring of malignancy.
Is it on the diagnosis or is it on the follow-up?
I think on diagnosis, sir. No, I'm not sure, sir.
We can turn to our experts, Anuruddha sir and Balagobi. What is your take on that?
In my opinion, it's harboring chance of cancer is very minimal. It's only 1%, but it's becoming the Bosniak 3 and 4 in a follow-up is about 10% chance.
Yes, I think that's what we wanted to highlight. This is the follow-up chances of developing malignancies in the follow-up period. So that is something of importance. And Gobi, you wanted to highlight anything about the importance of imaging in
Mahendra, I want to ask, what is the book you have referred, because it's nicely made presentation, and what's your reference?
Campbell, sir.
Campbell, okay. Yeah, so, and you were talking about the type 1 and type 2. Have you referred the EAU 2023 regarding the classifications of renal cancer?
No, sir.
Yeah, so the latest 2022 ISUP WHO says there's no type 1 and type 2 classification. So they just mentioned it's a papillary RCC. The previous type 1 now they are naming as classical papillary RCC. So that is a different. And can you tell what is T3A? When you will say that RCC is T3A?
When there is a involvement of the
renal vein,
renal vein and segmental veins. Yes.
One, yeah, that's a one T3A. Any other T3As?
Renal sinus involvement.
Yes, renal sinus involvement, renal sinus fat, renal hilar fat. Yeah, but any other things?
And collecting system involvement.
Yeah, so pelvic axial system involvement. That's the other one. Anything else? And the perirenal fat infiltration, isn't it? So out of these 4 T3As, which one is they think the pathologist thing is most aggressive T3A, and they want to take it that T3A to the some other maybe T3B or T3C in future? Which one you think?
So involvement collecting systems.
They think the hilar fat, the sinus fat involvement, they think it's a poor prognosis. So they want to change the T3A in future. So what is T1A?
T1 is less than 4 centimeters.
And what is the definition of small renal mass? What size cutoff?
So less than 4 centimeters.
Okay, again, so they are worried. I think there's a confusion whether it's a 3 centimeter or 4 centimeter in the definition. So again, they are worried about that number, right? And you were talking about the contrast. So in future, you had to read about the type of contrast and the incidence of allergies with each type of contrast. So they might ask in the Viva. And you told about nephrogenic systemic fibrosis. In that condition, where you develop fibrosis? Is it in the kidney or is somewhere else?
It's a systemic, not in the systemic.
Yeah, so usually under the skin and other organs, right? Then T1A, do we have to do a CT chest?
So if there is no clinical symptoms, we can go ahead with chest X-ray and chest X-ray only, sir.
Okay, right. So what are the 2 benign tumors confuse the radiologist as RCC? Tell me 2 benign tumors which confuse the radiologist as RCC.
One is oncocytoma.
Yes.
The one is fat poor angiomyolipoma.
Very good. Thank you. That's all.
Gobi, that there's another entity where the pathologist will change the stage. Can you remember the renal, the study you did when you were in UK? That when the IVC thrombus.
Yes, sir. Yeah.
Pathologist might upgrade it.
So in IVC thrombus, if it is a solid thrombus, which have a very good prognosis, the median survival up to 54 months. If IVC thrombus is like a friable thrombus, very difficult to remove from the vein during the surgery, then the median survival is less than 1 year. So it's a bad prognosis depending on the type of the IVC thrombus you get during the surgery. Yes, sir.
Yeah. If the thrombus is attached to the IVC wall, they will upgrade the stage. No, that's the thing. Okay,
Yeah.
right.
Please.
I think you have asked. The other question is, will you do biopsies in oncocytomas? Be you interested in this?
Currently, I 1 week back, there was a patient came as RCC, young patient, 30 years. We have did all the VHL screening negative. Then in MDT, they said there is a central scar. It looks like a oncocytoma. Then I discussed with the pathologist. I asked whether the biopsy, because our conventional traditional teaching is biopsy is not much useful because we might have a heterogeneity in the chromophore RCC. So that can confuse the histology. But she said with the immunohistochemistry, biopsy with immunohistochemistry, now almost 100%, they can certainly diagnose oncocytoma. So there's a meta-analysis as well. The biopsy with immunohistochemistry. It's not just pure biopsy. So then we can do active surveillance with the annual or 6-monthly imaging, sir.
Right. Thank you. That's all from me, Nishant.
Okay, sir. Could I just ask you one more question, sir? For the benefit of the trainees also, what is the place for MRI in renal masses?
Other than pregnancy, we rarely do.
Gobi?
And, also, sir, for the fat poor AML, if it is confusing in the CT scan, the T2 MRI give more information. And in the T3 cancer with the IVC thrombus, to state the IVC thrombus, whether it's retrohepatic or supradiaphragmatic, or to see the extent of the tumor thrombus, they recommend MRI in staging.
Yeah. Thanks, Gobi. The other important thing for the MRI is that if there is, as you know, that if the IVC invasion is there, if you have to sort of differentiate IVC wall invasion from the IVC thrombus, because then it'll be like T3C. For that, of course, MRI is helpful according to literature. So you need to, if you suspect that if there is IVC wall invasion, we can differentiate from MR. Actually, it has to be MR venogram. Then the other important thing which comes to my mind is sometimes the bleeding into the cyst can really mimic RCC because of the varying enhancement pattern. So there is a place if they cannot differentiate from the RCC. So in other words, if there's any doubts of the diagnosis of RCC in the CT IVU, we can always ask for MR urogram, and that is another indication for MRI. Other than that, yeah, I agree with all of your points, Gobi and Anuruddha sir. Right, I think because of the time concerns, we can move to the next speaker. So we will be inviting Dr. Niranga Samarasinghe to talk about small renal mass and the management of localized RCC. Over to you, Niranga.
Okay. Good evening, sir, and my dear colleague. Today we are going to discuss of this small renal mass and localized renal cell cancer management as well. Small renal mass introduction, the classical definition is these are enhanced renal tumors which are less than 4 cm in axial diameter. As Balagopsa mentioned, so the place of renal biopsy in small renal mass. With the new technique of this coaxial technique, we can safely practice this small renal mass biopsy. The common indication in this EAU and AU guideline, if this lesion is more than 1 centimeter, if the lesion is radiologically indeterminate, as previously mentioned, this lipid poor angiomyolipoma, lymphoma or other metastasis from cancer, there's indication for renal biopsy. And also when we are embarking before this ablative therapy, we should get a histological diagnosis, is another indication. And there are patients selected for active surveillance. We should do a histological diagnosis. Other than that, the patient with metastatic renal cell cancer, to decide on systemic therapy also, there's an indication for renal biopsy. And also during this image follow-up of patients, if the tumor growth rate is more than 0.5 centimeter per year, and the tumor size doubling time less than 12 months, and increase in tumor size more than 4 centimeter, these are the indication. As selective indication, we can decide if the patient decision for the radical nephrectomy was partial nephrectomy in individualized decision making. As an example, in a young patient with large renal cell cancer, we can omit this partial nephrectomy if the tumor is in high grade pathology. In elderly patient with marginal renal function with large renal cells cancer, we may try to preserve by doing a partial nephrectomy if the tumor is in low grade. Then the contraindication for this renal cell biopsy, elderly patient who are selected for this watchful waiting, and if the image is having this typical feature of radiological contrast enhancement mass who is awaiting surgical management, there's no need of renal biopsy, which we are seeing in with a bit of malpractice in the current stages. And if there are cystic lesion without suspicious solid component, renal biopsy is contraindicated. As we mentioned, this coaxial technique biopsy, we can take multiple biopsies using to 16 to 18 French sheet. If we can combine this biopsy technique with FNAC, it will increase the accuracy of the biopsy gain. Even though with that, the 0 to 22% in the literature, they can be non-diagnostic. In those instances, we need to do repeat biopsy or surgery depending on the behavior of the tumor. We can take at least 2 cores from periphery of the lesion and especially from non-necrotic areas. So this technique will prevent crack seeding and upstaging of the tumor. And at the moment, available data shows none of the series does not show any seeding or significant post-procedure complications such as bleeding. When we go into management of small renal mass, we can consider surgical management, ablative therapy, active surveillance, and the watchful waiting. In the hand of the surgical management, the tendency and the evidence is more supporting this nephron sparing surgery. So we should always, the upper should be the partial nephrectomy. In the data and available evidence, the partial nephrectomy having versus radical nephrectomy, the partial nephrectomy is equal in survival benefit, equal radical nephrectomy, and it has a good preserving of kidney function advantage as well. And they have demonstrated this overall survival advantage in young patients, mainly indicating there's a reduction in cardiovascular complication. If we consider the surgical technique of this partial nephrectomy, whether we are going to occur open, laparoscopic, or robotic, the available data shows this laparoscopic technique has the advantage of this reduced hospital stay, reduced use of analgesics, and early recovery to non-strenuous work. But the drawbacks are there's increased surgical time, and there's a risk of the increasement of warm ischemia time, because this acute tubular necrosis occur at 25-minute interval. So we should be alert on this. And if there's a patient with this von Hippel-Lindau disease with multiple tumors or complex tumor, we can use this cooling method, where we can use this cold ischemia concept up to 45 to 50 minutes. And in the current data, the robotics, there's a advantage of less warm ischemia time, but this learning curve and availability is the drawback. Then, as mentioned by previous speaker, we can use this nephrectomy scores to decide on anatomical location, like renal Padua and C index. Other two are this ABC is the arterial-based complexity score, and there's another score known as zonal nephro score, where the kidney is divided into zones and given a scoring system. The same anatomical concepts are used. And what should be the tumor margin after partial nephrectomy? So currently, 1 millimeter margin with kidney tissue trim is accepted. This concept of one cell layer clearance is not properly advocated by the histopathologist. And so during surgery, we can use this intraoperative ultrasound scan to assess the deep margin of the tumor. And newer technique like this firefly technique with injection of contrast dye during surgery to demonstrate the tumor and the normal tissue. And practically using this tumor-based diathermy can be used to prevent this tumor margin positivity. And the phase of enucleation, it is also accepted practice with current data in cases of von Hippel-Lindau disease and when there are multiple tumors. But the drawback is if the tumor type, if high-grade tumors like sarcoid or rhabdoid tumor type, there's a risk of local recurrence. If histology came as a margin positive after partial nephrectomy, what we should be done? So this phenomena mostly observed in when there's an adverse histological type with high-grade tumors, is rhabdoid and sarcoid differentiation. If there are bilateral tumors, so in a solitary kidney when there's a tumor. So this will increase the risk of local recurrence by 5-fold. If there's a margin negative, the local recurrence rate will be around 3%. If the margin is positive, it will go up to 16%. But becoming margin positive does not increase the risk of metastasis or overall survival of the patient. So we can, as the management, we can do intense surveillance position or can offer local ablative treatment. The option of resection and radical nephrectomy considered as an over-treatment for this kind of patients. Then the ablative techniques availability. So we can use this for this patient who are not fit enough for surgery. So we can use this either by percutaneous technique or laparoscopic technique. The main two types in clinical practice are the cryoablation, the cold method, and the radiofrequency ablation, the photothermal method. In cryoablation, the advantages are we can see this real-time image of the ice ball with uniform ablation. So the tumor margin is very clear during the procedure. The advantage, we can use multiple probes. If we are doing this as a laparoscopic surgery, we can use this intraoperative ultrasound probe to assess the tumor margin. So it will give less tumor margin positivity in this assessment. But so this will give more metastasis-free survival than the radiofrequency ablation. In radiofrequency ablation, as we are using this thermal energy, the drawback is there's a more renal tissue damage as tumor margins are not clear. And even though it, in the data, it has associated less post-procedure complication. At the moment, there are many ablative techniques emerging with microwave, laser, HIFU, and electroporation. And those techniques, even in 2023 guideline, still they are taken as option. But the current data is not strongly recommending it. So if we are comparing this ablation therapy versus partial nephrectomy, the partial nephrectomy surgical management is always superior because it increases the overall survival, disease-free survival, recurrence-free survival, and post-specific survival. And it will also has a minimal local recurrence rate and the metastasis. With cryoablation, it has equal quality of life and complication compared to partial nephrectomy. If we take both three methods, considering survival benefit, partial nephrectomy has the most one, then cryoablation, then the radiofrequency ablation comes as the third option. And this concept of this active surveillance and the watchful waiting, the active surveillance comes with this curative intention for patients. It's a new concept started in recent decades. So during this one, we will do the image follow-up, strict follow-up of the patient at 3-6 month interval, then 6 monthly for 3 years, then yearly with CT follow-up with image. There we are assessing this growth rate of the tumor, whether it's more than 5 millimeter per year, doubling size less than 12 months, and if the tumor size more than 4 centimeter during follow-up. So these will be indication for rebiopsy or upstaging of our management. Then the watchful waiting, we are doing with the palliative intention for elderly and comorbid patient. So there's no need of image follow-up or strict surveillance strategy. And then we can focus on this localized renal cell cancer. These are T1 and T2 tumors, N0, M0 stages. So here the discussion is about whether go for a partial nephrectomy versus radical nephrectomy. So indicate as an absolute indication for partial nephrectomy. So those are the indication if we have when the patient is anatomically or functionally anephric, if we have done a radical nephrectomy for those patients, like bilateral renal cell cancer, single functioning kidney renal cell cancer. and when the congenital kidney is having a pre-existing severe renal impairment. So the relative contraindication are the relative indication are the pre-existing CKD or patient developing future risk of developing CKD and T1A tumors, and also considered in anatomical positions in T1B and T2 tumors as relative indication for partial nephrectomy. So at the current, the recommendation is more toward partial nephrectomy. And as there are many available data are the retrospective studies, and there are a few randomized control trial as well. As advantage, they have mentioned this advantage of preservation of kidney function and reduction of risk of cardiovascular event. And there's overall increasement of quality of life with partial nephrectomy. And it is the preferred surgical modality in CKD patient. In the research, they have assessed the more than 7 centimeter tumors, which show this increased overall survival benefit. And it was associated in some researchers with reduced mortality benefit as well. And there was some research where they have assessed the tumors less than 5 centimeter with partial nephrectomy versus radical nephrectomy. So both show equal survival and complication and time to recurrence. They have done this Medicare database analysis with the elderly population, more than 75 years elderly population. There the surgical outcome was equal to non-surgical management. But there was another controversial studies. Some studies have shown even at the age of the 75 to 80 years, some may have this better overall survival after surgery. So the evidence, there are some conflicting evidence on when it's come to old age. So the current EAU recommendations are, we can offer this for localized renal cell cancer, T1 and T2 is the surgical management is the option. And for this T1 lesion, partial nephrectomy is the preferred treatment. If we consider this AU recommendation, so they have given us the indication for radical nephrectomy as high-grade complex tumors, and the congenital kidney should be normal, except above, always their preferred treatment method is the partial nephrectomy. So both guidelines referring more toward the partial nephrectomy management. So we should consider other factors as well as previously mentioned, the patient fitness and the renal function test. The EGFR cutoff is taken as less than 60, and the albuminuria and patient preference and ability to be followed up, and life expectancy and the tumor factors as well. We can observe after radical nephrectomy, there's an improvement of EGFR that is mainly due to compensatory hypertrophy of the remaining kidney and the hyperfiltration by the congenital kidney. So whether we should go for adrenalectomy or not. Previously,
3 more minutes.
Okay. Previously, they have a belief on with this dog study, the adrenalectomy has a benefit, but current evidence, it doesn't affect overall survival at 5 year or 10 year survival. There was a prospective non-randomized control trial where they have assessed 2006 radical nephrectomy. Out of them, only 48 underwent adrenalectomy, even though they have done 48, the 42 were benign. So the position of upper fold does not always indicate the adrenal involvement, but increased tumor size may be indicative of the risk. So EA recommendation for adrenalectomy only clinically or radiological involvement only. And the place of lymph node dissection, the indications for this one also CT-MR detect the lymph node masses because they are not sensitive enough for this lymph node detection by radiologically, and palpable lymph node masses during surgery. This also does not give a metastatic or mortality reducing benefit if we decide on a lymph node dissection, but it does not increase the risk of complication. Hospital stay according to the data. But there's some benefit of survival in high-grade renal cell cancer with sarcomatide and large tumor volumes. If we can take this as a prognostic indicator. If there's an extracapsular extension or more than 4 lymph nodes are positive, those are poor prognostic indicators. On this randomized control trial, only 4% of renal cell cancers have this lymph node spread, giving a staging benefit. If we decide on lymph node dissection, the level of lymph node dissection, because this renal cell cancer can have skip lesion, so the extended lymph node dissection should be this para-aortic caval or inter-aortic caval level, starting from the diaphragm cusp to the external iliac level. At least 15 lymph nodes should be in node. So this lymph node dissection is only for staged and local control benefit is there in the data. And the surgical radical nephrectomy technique, whether open versus laparoscopy. At the moment, no randomized control on direct comparison, but there were cohort and retrospective data show no difference on overall oncological outcome. The open surgery, the approach, whether we are going for transperitoneal or retroperitoneal, both are equal in neurological outcome. Whether we are going for a laparoscopic surgery or hand assisted or robotic, both are having more or less equal outcome. And this EA recommendation for this, the laparoscopic radical nephrectomy has lower morbidity compared to the open method. In T1 and T2A renal cell cancer, they are both equal in oncological outcome. So as indication for laparoscopic radical nephrectomy, T2 and localized renal cancer, when they are not amendable for partial nephrectomy only, we should offer this radical nephrectomy. This post-op follow-up of the patient will depend on the survival benefit, depend on the risk stratification. We are using many risk stratification systems like Lebowitz score, where we are assessing the predict of the metastasis, considering the T stage, size, lymph node, nuclear gradient, tumor necrosis. There are other this nomogram and this university scoring and SSIGN scoring. Almost all they are assessing these tumor factors, and in some they are assessing the patient factors as well. So depending on the staging system, we can divide patient to low risk group or intermediate and high risk group. For the low risk group, previous recommendation was to do ultrasound guided follow-up in 6 months, then 1 year CT and 2 year again ultrasound scan. But in the 2022 EA guideline, now this ultrasound follow-up is omitted. They have recommended for CT follow-up, but the duration of follow-up will be different. For the low risk group, they are asking for a 6-month CT and more near CTs, relatively far CT interval, and for the high risk group, strict follow-up with close by CT at 3 months, 6 months, and 12-month interval. So this follow-up, we should decide on the risk stratification only. And thank you, sir.
All right, thank you. Thank you very much, Niranga. It was a very comprehensive talk. Could I ask you a small question about the outcome of surgery for small renal masses? Are there any methods that you can predict the outcome and complications for small renal masses? Any scoring systems?
The metastasis we can assess by this Lebowitz score.
Well, outcome of surgical complications. Are there any particular assessment tools we have? Nephromet score and the
Yes, anatomy. Yes, sir.
Yeah. Okay. So, can you do you have any idea what the nephrometry score is, and what does it sort of mean when you're having a discussion with the patient about a particular renal lesion? How do you sort of interpret the finding of the nephrometry score and correlate it with the patient's surgical outcome?
In the nephrometry score, we can assess the anatomical position of the tumor. We are using the tumor location and its exophytic or endophytic, then the size of the tumor and the closeness and nearness to the renal hilum, and the relation in position to the polar lines. The denominators of anterior posterior are given, but they are not given a score. So out of this 12 score, if the score is less than 4, we can guess the low risk, and more than 6 and 7 is mild to an high risk patient. So depending on this location, we can decide whether this patient is suitable for a partial nephrectomy. And other than this scope, patient factor should be also considered before the decision making.
Yes, yes, very good. That's what we wanted to tell. So if you can just, as roughly, you can tell the score, and then you can correlate the complications. So up to about 6, you can say around 6% risk of developing complications. And if the score is around 6 to 9, around 11%. And if the score goes beyond 9, it will be around about 20% of complications. So you can counsel the patient accordingly. Let's ask the expert panel. Gobi, do you have any Questions for Niranga?
I want to ask Niranga, what are
Yes,
the
sir.
three negatives about or three complications you encounter in partial nephrectomy when compared to the radical nephrectomy? Those are specific to partial nephrectomy. Yeah, more specific.
In partial nephrectomy, there can be increase in this warm ischemia time with the technical issue, and there's a risk of intraoperative bleeding risk when you're achieving the hemostasis, and there's a possibility of becoming this post-operatively, logically the margin involvement if the dissection is not far away from the tumor base, and risk of local recurrence is there, and we need should active proper surveillance after surgery.
Okay, so urine leak is one, post-op urine leak if you the system, and the reactionary hemorrhage and intraoperative hemorrhage. The third one is a positive margin. Those are the three major issues specific for the partial nephrectomy. And you said about ablation, like radio frequency ablation and microwave. After ablation, how will you assess the success of the ablation? How you can say, cryo, of course, you can, during procedure, you can see ice ball formation. In an ablation, how you assess it is successful?
We can offer post-operative this image follow-up for the patient with the contrast CT studies.
Yeah, so by doing contrast study, how do they say is successful? You will see non-enhancing areas. That's a dead tissue, necrotic tissue. So previously enhancing tumor is not now enhancing mean, it's all necros. So that's the way. Then you said during robotic partial nephrectomy, the warm ischemia time is less.
Yes, sir.
What is the reason when compared to the laparoscopic partial nephrectomy? In robotic partial nephrectomy, the warm ischemia is less.
It has a more control than this laparoscopic techniques. Easier to do the
basically suturing and resections are very easy because the movements are in the wrist joint and finger rather than in the elbow joint. So that's the reason. Yes. Then if you are looking the histology after the radical nephrectomy or partial nephrectomy, what are the specific thing you will look in the histology? Of course, you will see the type of the histology, type of the cancer and TNM. What are the other things you will see in the histology report?
I will look for this poor prognostic markers like this rhabdoid and sulfur differentiation, perineural invasion, and vascular invasion. And the margin of the tumor, if it's a partial nephrectomy, the margin overall away in millimeters. And
and one more thing that is included in the Libovich prognostic scoring as well. What is that? The extent of the tumor necrosis.
And tumor necrosis, tumor necrosis.
Okay. Then you said 1 millimeter or even 1 cell margin is adequate for a partial nephrectomy. And the reason for that is already explained by Mahendra. What is the reason? Why the 1 cell margin, even enucleation is adequate? Why is that?
Because there's a pseudocapsule formation. There's pseudocapsule formation around the tumors in most of them.
Yeah, most of the renal cancers are non-infiltrative, isn't it? So they are compressive or expansile rather than infiltrative, except, as he said, the sarcomatoid variant and collecting duct cancer and medullary cancer. And most of the cancers are non-infiltrative. Yeah. Then what is the place of DMSA in RCC management? Or DMSA or DTPA? Isotope scan, any place?
That is, I'm not sure, sir.
Suppose if a contralateral kidney looks small, and patient is asking the lot of questions, then you have to do a split. You have to check the split function, and you have to mathematically explain the patient. If EGFR is 60, proportionally the force of the EGFR will be this much. So in some difficult situation, this is useful. And you said about more than 75 years, the benefit of surgeries may be limited. So rather than going by the age, will you use any other factors when you
Patient
decide?
performance stage, Carnot stage.
Okay, one is Karnofsky score. Any other system you know to assess the patient fitness? Maybe you have studied in the MD, like similar to Karnofsky. Anything else?
ECOG level of the
Yeah, ECOG. And anything that mentioned in the EAU? You know CCI? What is CCI? The Charlson Comorbidity Index. Okay, the CCI.
Okay.
Charlson Comorbidity Index. Right. Yeah. And those are the questions I want to ask. Yes.
Okay.
Anuruddha sir, are there any important
No questions, Nishant. I hope all the trainees will realize that the questions that Nishant and Bhargav are asking are exactly the questions that you will be asked at the exam. So very important to remember these things, answers, how to answer these things. Last time also.
Yes, sir. Yes, definitely. Just to add a couple more things for the biopsy, I think the trainees should remember that if somebody asks you whether you're going to do a biopsy for a small renal mass or any renal lesion, you need to prove that that whether your management is going to be changed by doing that. So, so if you just you can't just offer biopsy, as very clearly mentioned by the by Neranga, that it could be all those indications. You need to know all these indications for biopsy. Those are the sort of absolute indications, but there is a place for relative indications, like, for example, if you really wanted to know whether this is aggressive tumor or not, because that might change your decisions between partial nephrectomy and the radical nephrectomy. So that is something that you should remember. I think we can move to the next speaker now. That will be Dr. Chaminda Alahakon. So he will be discussing about management of advanced renal cell carcinoma. Over to you, Chaminda. Try to stick to the 15 minutes time slot. Thanks.
Okay, thank you very much, sir. And good evening all. And today I am going to discuss something about the management of advanced renal cell cancer. And today I am going to discuss a little bit about this locally advanced renal cell cancer. I am going to discuss about something about the tumor thrombi management, and as well as lymph node involvement and the lymph node dissection, and also something about the unresectable locally advanced cancer. And also I'm going to touch on metastatic renal cancer as well. So when moving about this management of venous tumor thrombus, this tumor thrombus formation per se is considered as a significant adverse prognostic factor. Though the common thinking is that this is a late event in the progression of the renal cell cancer, but this recent evidence came from this TraceX renal cohort. They show that this is an early event in the cancer growth, associated with some specific histological types. Before going into the surgical management of this venous tumor thrombus, it's very important to know whether there is an associated bland thrombus. Because the presence of bland thrombus, which might obstruct these lumbar veins, that might lead to formation of high pressure collaterals around the tumor. So in that case, during the surgery, our surgery might complicate with severe bleeding. Apart from that, the presence of this bland thrombus can cause embolism and post-operative morbidity and mortality. So this identification usually can be done with our usual contrast enhanced CT imaging, where this normal tumor thrombus usually arising at the level of this renal vein ostium, and it will grow in the capillary direction, and also the enhancement pattern of the renal tumor thrombus as equal as to the primary tumor. So if there are any bland thrombus, So it's advisable to remove it, but if it is very solid and fixed, so we can left it in place. When considering the classification of this tumor thrombi, so usually we can see it is on the TMM classification as well, but more practical and surgical relevant classification is given in the Mayo's classification. So it will classify according to the extent along the IVC and as well as in relation to the hepatic vein. When considered surgical management, usually it is a multidisciplinary approach with the urologist, vascular surgeon, and if necessary with the cardiothoracic surgeon. Approach could be open, laparoscopic, or robotic assisted. And the data coming from the Western countries, so they shows that this minimally invasive approach is more favorable for the reduction of the rate of transfusion as well as overall complication rate. But however, this major complications rates were similar for open thrombectomy. And theoretically, so this renal, if there's a venous tumor thrombus, so the involvement of adrenal also very high. So usually they are this usually the adrenalectomy also indicated in that occasion. So tumor thrombus extraction, usually we are going to do it by the milking, but if it is adherent, we might need to take a part of venous wall or a part of IVC. So the reconstruction will depend on this vascular surgical principles on IVC repair. When considering this tumor thrombus management in the metastatic disease as usual phenomena, so we are not going to do this primary surgery with this radical nephrectomy for the metastatic disease, but if it is a low risk patient with resectable metastasis, then the EUA recommendation is to go for a venous tumor thrombus excision. And when considering the neoadjuvant treatment, hoping that this tumor thrombus will downgrade into its level, but recent available data didn't show any significant reduction of the thrombus level by giving the neoadjuvant treatment. So it is not further recommended. And also we can consider about IVC filter before preoperative period to avoid these postoperative complications, but EUA doesn't recommend this due to this increased rate of tumor fragmentation with the IVC filter replacement, as well as there will be practical infeasibility due to the if it is beyond Mayo's classification 2 or more. Then we'll move into the lymph node management, as previous Narang has talked about something about the lymph node management. So this lymph node dissection was a point of contention for more than 5 decades, but initially those were people who usually did the lymph node dissection with the radical nephrectomy, but now the favor is falling out. The causes behind are that some evidences, those are level 1 evidences that will question the cancer specific survival in this with the lymph node dissection, as well as there are more definitive surgical templates and surgical indications for lymph node dissection. But clinical detection of the lymph node invasion is important for deciding the prognosis as well as the follow-up. So we use this traditional imaging, including the ultrasound, CT, or MRI. Those have limited reliability due to this limited sensitivity as well as specificity. And then there are these perform normograms which can use preoperatively or intraoperatively. So those have some advanced high accuracy level for deciding on the clinically positive lymph nodes. There are proposed algorithms which can use to selection of the patients for the lymph node dissection. The practical use is still doubt. When considering the survival data, so if the patient is having this low risk and as well as clinically negative lymph node, so the lymph node dissection usually doesn't have effect on overall survival and progression-free survival. Those were elicited by this phase 3 randomized trial, URTC trial. But when comparing the other high-risk patients or patients with established metastasis, then the available data also contradictory, so whether there's any improvement or not. So due to those reasons, the current recommendation from the EUA is, if there is a clinically detectable enlarged lymph nodes during the nephrectomy, they encourage us to do the lymph node dissection. This is for the staging, prognosis, and follow-up implications. Then moving into the adjuvant treatment following the radical nephrectomy, and with this targeted therapy. So the available data again the contradictory. So the first we move on to this randomized phase 3 trial, where this extract trial, which is funded by the Pfizer group. So they compare this adjuvant sunitinib versus nephrectomy along with the placebo, and there they found that there is increased median disease-free survival. But another phase 3 randomized trial is Assure trial, which is an unfunded trial, and they failed to demonstrate this advantage. So due to those reasons, this EUA doesn't recommend adjuvant treatment with this targeted therapy further. But when it comes to this immunocheckpoint inhibitors, there are few trials which giving this, which will shows that there's a benefit with the adjuvant checkpoint inhibitor with after the radical nephrectomy. So one of these is the Keynote 564 trial, where they compare the patients with radical nephrectomy with placebo and this radical nephrectomy followed by systemic pembrolizumab. So they found that there is a increased disease-free survival with this. So the EUA recommendation is, due to this unfavorable adverse side effect profile and no survival advantage, usually this targeted therapy is not further recommended. But if there are any high risk of recurrence, the adjuvant with pembrolizumab can be used. When moving into this management of locally advanced unresectable cancers, the management basically depends on the systemic therapy. So usually, if there's we can go for this local treatment strategies for control the symptoms, including this visible hematuria. Moving on to the last part of my discussion, that is metastatic renal cell cancer. Usually, approximately around 30% of patients diagnosed with renal cell cancer have metastatic disease presentation. This is from the British Journal of Urology. And their median survival was around 12 months. When going into this management of metastatic renal cell cancer, there's this debate on cytoreductive surgery in metastatic renal cancer is a very famous topic. So usually there is no place for cytoreductive nephrectomy alone, but when it comes to this, goes back into this interferon, systemic interferon era. So there were two randomized trial which demonstrate that there is a benefit of doing cytoreductive nephrectomy with this systemic immunotherapy, basically with this interferon alpha 2b. So they found that with cytoreductive nephrectomy and this systemic interferon 2 alpha b have having an increased overall survival rate rather than going with systemic therapy alone. But then this with this tyrosine kinase, so targeted therapy era, so there are those two landmark trials which demonstrate that there is no place for cytoreductive nephrectomy along with the systemic therapy, with the targeted therapy. The famous Carmina trial, they compare the patient with sunitinib alone versus sunitinib plus cytoreductive nephrectomy, and they found there were no added advantage by doing the surgery cytoreductive nephrectomy than the systemic sunitinib. And another trial, that is certain trial, where they compare the patients with systemic therapy with the sunitinib with immediate cytoreductive nephrectomy versus deferred cytoreductive nephrectomy, and they found there is no added benefit by doing the deferred cytoreductive nephrectomy. Apart from that, they could able to identify the patients with resistant to systemic therapy as well. So due to those reasons, EUA also doesn't recommend to do the cytoreductive nephrectomy with the systemic targeted therapy in the metastatic renal cell cancer. And there are ongoing clinical trials to see the effectivity of this cytoreductive nephrectomy with checkpoint inhibitors. One of these trials is demonstrated here. Those are probe trials. Those are still going on. When we are talking about a little bit about this drug therapy, the target therapy, we commonly use this tyrosine kinase inhibitors, which are usually targeted on this vascular endothelial growth factor and the platelet-derived growth factor inhibition. And the usual drugs are this sunitinib, sorafenib, and pazopanib. Out of those, this pazopanib has lower side effect profile. There are the common adverse effects include this hand, foot, skin reaction, and stomatitis, and as well as few other fatigue and diarrhea. But also they are having this serious grade Calvin grade 3 or 4 adverse event in the less than 10% of the patients. And something about checkpoint inhibitors, those are usually this tumor cells has ability to evasion of the immune response. Usually in this cell cycle checkpoint, they are having this checkpoint inhibitors, cell cycle checkpoints. So this tumor cell has ability to evasion of these points. So those include this PD1 receptor and CTLA receptor. So the drugs which will bind to those can restore the tumor specific T cell destruction to the tumor. When considering those two groups of drugs, checkpoint inhibitors versus the tyrosine kinase inhibitors, so now the trend is to define which one is far more better. So there are several trials. One is this Checkmate 214 trial. So they found there's overall survival and objective response rates were significantly higher with this immune checkpoint inhibitor. This is nivolumab and ipilimumab. When it comes to this low risk disease with oligometastasis, that is means that the risk of this metastasis recurrence also reduced, and as well as there are few mets which can be resected. In that case, we can go for the radical nephrectomy with metastatectomy or even with the local therapy. But after doing this removal of the oligomets, EUA doesn't recommend to offer tyrosine kinase inhibitor for as a adjuvant treatment in this group. Thank you.
Thank you, Chaminda. Last few questions. What percentage of tumors usually come present with venous involvement when it comes to RCC?
Yeah, it is about less than 10% of tumors usually present with this tumor thrombus, and usually clear cell cancers. Around 80% of them are clear cell renal cell cancer.
Yes, good. And what do you think about the prognosis of somebody coming with a large renal thrombus? What sort of prognosis we can predict coming with a tumor thrombus in the IBC with the large renal cell cancer?
Yes, it is this tumor thrombus is an adverse prognostic factor. So, so in this case, there will be this high surgical morbidity to the patient. So the patient morbidity also in
if you do a successful surgery,
also,
if you do a successful surgery, what do you think about the prognosis? Any idea?
Then it is almost same as the localized tumor cell.
It is not as localized tumor, but it's around 40% in the literature. So that's why such a huge, a significantly advanced disease. But even if it goes to the right atrium, if it is non-metastatic, and if you do offer the proper surgical control, the 5 years viral rate will be around 40%, so which is significant for such an advanced disease. And we'll go to the experts, and I would ask, just before moving, so what is in your practice, would you offer lymphadenectomy, or do you do routine lymphadenectomy, or what is your approach for RCC and lymph nodes?
Practically, we usually don't go for this lymph node dissection about the surgical template from this surgical crust to this diaphragmatic crust to the this iliac vessels. But if there are any visible nodes, we go for this very picking type of lymph node dissection.
Yes, very good. We'll ask Govi to ask a few questions. Govi and
Chaminda, what are the issues with the Carmina trial? Why some surgeons, they are not, they are against the Carmina trial? What are the issues with the Carmina trial?
One thing is, so it is also a funded trial, so the bias is there. And
regarding the type of patient included in the study.
yes, so those are very low risk patients, so low risk category patients. So the and
low risk or high risk?
Sorry, sir.
Yeah. So most of the patients had a poor performance. So anyway, they will have a poor survival with surgery. So their risk stratification was poor according to the. What are the risk stratification, regarding the metastasis in RCC?
So there is this MCFK stratification.
One is, MSKCC, isn't it? Or both are similar, or IMDC. So that based on that, so there are issues with the patient selection issues are there with Carmina trial. Then you said about, okay, if a tumor thrombus is in the renal vein, just entering into the IVC, how will you operate? How will you remove that thrombus?
Yes, so in that case, it's a Mayo type 1. So we can take it by milking without doing the venotomy from this.
So how are you going to control the IVC?
In that case, we don't have to do the full mobilization of the liver. So we can take this control from the just below the liver, so the upper IVC control take.
Yeah, what about doing a side clamming and then divide the vein and then pull the thrombus? If a thrombus is not infiltrating into the wall, that is one of the feasible thing, isn't it? Right. Then regarding the checkpoint inhibitors, it's not widely available in most of the centers. What is the main issue with the checkpoint inhibitors? Like nivolumab, ipilimumab. So what is the problem? They are good. They have a efficacy wise, they are better than the tyrosine kinase inhibitors. But the immunotherapy, what is the problem? Why they are only used in highly specialized centers? That is because of the side effects, isn't it? Clavy and Dindo, 4 and 5 side effects are very common, and so it should be treated in a highly specialized centers, isn't it? Yeah. Thank you. Another sir.
No, I have no questions. Nishant, so metastatic ones, these apart from the exam.
Yes.
You don't do nephrectomy now, Nishant, or how?
I think, sir, for the metastatic renal cell carcinomas, because of this Carmina trial evidence, I think, as far as I remember, only the high risk category have some benefit of doing
Yes.
the cytoreductive nephrectomy, sir. And
Basically,
yeah, yes.
for patient with good performance status, young age, no systemic symptoms with the tumor, that is a favorable risk, low intermediate risk, then we can go for a
That's right.
cytorectomy and manage the metastasis if it is oligometastasis. Patient with high intermediate risk or poor risk according to the IMDC, and if they have a significant systemic symptoms from the metastatic burden, then they have a limited benefit with the surgery.
Yeah, because I continue to do cytoreductive nephrectomy because that will relieve the local symptoms as well, Nishant and Balabori, because otherwise these fellows will come with hematuria suddenly and we are really stuck.
Yes, sir. So they say if a tumor burden in the kidney is more than the metastasis, there are benefit with the cytorenectomy. If a tumor burden in the system is more than the kidney, then there is a limited benefit. There's not much benefit.
Okay, thank you.
And Chaminda, you said that there's no proven benefit on giving adjuvant chemotherapy or adjuvant immune therapy. So any other modalities of controlling the tumor, if that helps? You heard anything?
Adjuvant treatment wise?
Yeah, what sort of any adjuvant even procedures? Have you heard of any procedures?
I'm not very sure about that.
Minimal invasive.
Yeah, minimal invasive things. If there is a large IVC thrombus, you could offer them embolization, isn't it? But what is the problem with the embolization? Any idea? If you embolize them well beforehand, they will develop severe pain, and they might even have tumor necrosis, and sort of due to the tumor necrosis, there will be a lot of cytokine release, and they'll be a bit unwell if you do it sort of well beforehand. But many other places, the literature recommends that if you want to go for a embolization, you can go for a embolization on the same day. So you can, when you're doing the surgery, you can same day, you can send him for embolization. And it is like you're starting the surgery with a clip on the renal artery. So your bleeding complications will be less, and patients might not have time to develop any significant side effects. So yeah, I think other than that, there are many centers still, I think, practice some immunotherapy as a neoadjuvant therapy, but many places has given up that practice. So that was a very good discussion. So for the next part of the program, we will be having some journal article discussions related to the renal cancer. So I would invite Dr. Hilary to conduct the next bit. Hilary, over to you.
Very good evening, everybody. So we move on to the journal article discussion. We will have 2 journals discussed today. So each presenter will have 12 minutes, and we'll have 5 minutes for the discussion. So let me invite the first.
Yeah, thank you very much, sir, and my dear colleagues. I would like to present a systemic review and a meta-analysis which was conducted assessing the use of adjuvant immunotherapy in renal cell cancer. Incidence of renal cell cancer globally, which is around nearly 4 lakhs per year, and the morbidity also high with more than 1 lakh. And the main standard of care is for localized renal cell cancers are nephrectomy, and although despite of this surgical treatment, there is still a high risk of recurrence, and especially these recurrences are associated with high risk characteristics like advanced tumor stage, the tumor biology, as well as the lymph node involvement and the metastasis. And for this control of further recurrences, apart from surgery, they have invented these adjuvant treatments, and apart from them, they are the tyrosine kinase inhibitors. They have assessed in 6 trials, but still, apart from STRAC trial, which was discussed by my previous colleague, others failed to show any benefit of disease-free survival. And recently, these mammalian target inhibitors like mTOR inhibitors, everolimus, showed a disease-free survival, but it has its high hazard ratio is less, so it also doesn't show significant improvement. And so that contemporary use of the adjuvant treatment was immune checkpoint inhibitors, which was there are several trials, and this is used in metastatic renal cell cancer. So for them now there's growing interest of using these immune checkpoint inhibitors in the use of high-risk localized renal cell cancers as an adjuvant treatment. So my previous colleague discussed what are these immune checkpoint inhibitors. Briefly, the tumor in our immunity shows there's tumor immunity. So some tumor cells has the escape pathways by neutralizing these T cells by these ligands, PD-L1 and CTLA are the common ligands they have identified. And these drugs have been made to target these ligands and to neutralize them, thereby enhancing our tumor immunity against the tumor cells. For example, we use ipilimumab, nivolumab, pembrolizumab. The common use malignancies are melanomas, renal cell cancers, and lymphomas are using. So to assess the use of this adjuvant treatment, they have conducted a systemic review and a meta-analysis, which was conducted by a group in Houston Methodist Hospital. And the objectives they want to highlight is to assess the disease-free survival of these immune checkpoint inhibitors, as well as they want to assess the secondary outcomes, the adverse effects of immune-related adverse effects, and the treatment discontinuation due to these adverse effects. So they selected previous research and trials according to the PRIMSA guidelines, and they as sources they use PubMed, Embase, and these relevant conferences which was conducted up to 2022, where they searched about the use of immune checkpoint inhibitors versus placebo or the observation groups, and same time they use the researchers which assess program PD-L1 receptor analysis as well as this high-risk sarcomatoid features. And this is their PRIMSA guideline, where they first isolated researchers which include their criteria and then do the screening. Out of the majority got excluded because of the heterogeneity and the selective criteria. And lastly, they included only 4 studies as their systemic review and for the meta-analysis. So they summarized the results. It came as that the results are not conclusive in view of demonstrating a disease-free survival. Only one research shows the evidences of disease-free survival because of the heterogeneity. And as secondary outcome, they found that the tumors which showed positive PD-L1 expression and same time tumors which showed sarcomatoid features showed a significant benefit of immune checkpoint inhibitors with a hazard ratio of 0.72 to 0.59. So this is the research which shows the use of this immune checkpoint inhibitors as disease-free survival benefit. It was Keynote 564 trial, which used this pembrolizumab as the immune checkpoint inhibitor, and there was disease-free survival benefit. And these other 3 trials, this iMotion and Prosper, Checkmate, those trials also use immune checkpoint inhibitors along with placebo or sometimes with a dual treatment, but they doesn't show significant disease-free survival. So for the conclusion, they couldn't get a direct conclusion of the use of ICIs, so it has mixed results was there. But however, patients with PD-L1 expression and sarcomatous features show a benefit of disease-free survival by the use of immunotherapy. For that, the future-wise, we need to move on to more researches which shows this overall benefit of adjuvant treatment in localized high-risk renal cell cancer. And same time, current recommendation shows weak recommendation against this use of adjuvant treatment for high-risk localized renal cell cancers. Right. Thank you very much.
Thank you, Dinendra. Now the floor is open for discussion. And I would like to invite the experts, Anuruddha sir, Dr. Nishanta and Gobi. Any comments on these?
So basically, still the surgery is the best for
Yes,
localized disease, isn't it, Dinendra? So do
yes,
a good surgical resection without delay. That will give the best outcome.
yes.
I think we can move to the next.
Yeah.
Okay. So journal number 2, Dr. Sanjay Marasinghe, you have 12 minutes and we'll again have 5 minutes for the discussion bit.
Okay. I'm going to give a recent article published in the BJU article regarding the systematic review of regarding the tyrosine kinase inhibitor treatment for renal cell carcinoma with the venous tumor thrombus. So this is a quantitative summary, and it says that 4 to 15% of cases, the patients with the renal cell carcinoma has venous tumor thrombus involving the renal end and the IVC. So the problem is the venous tumor thrombus is there's a high chance of perioperative complication and morbidity because of the complexity of the surgery. So the complication and morbidity and mortality increase with the extent of the tumor thrombus along with the IVC. So, and it says about the perioperative mortality is 5 to 15%, and so this systematic review is try to highlight whether the neoadjuvant systemic treatment, tyrosine kinase inhibitors, will reduce the tumor thrombus level and the height, and also the surgical complication and morbidity. So this is a quantitative analysis. So it's a systematic review. So it's a kind of a gold standard of scientific evidence. And this has been registered in the Open Science Frameworks Registry, and they have used this Midline, Embase, and Web of Science and Cochrane Center's Register of Control Trial database to systematically review. And they use this ECOS framework to formulate the eligible criteria to systematic review. So they assess the primary outcome, the changes in the VVT length and the VTT level. Secondary outcome as they check the adverse events during TKI and the perioperative complications. So they have found 10 retrospective observation studies and 1 prospective trial. So 4 studies are multicentric and 7 are single-center studies, and the studies are originated from Europe and 6 from Asia and 2 from North America. So most of these patients have clear cell RCC, and they have calculated the median number of treatment cycles was 2, and they have given the treatment for median treatment for 3 months. And this is a quantitative summary. So according to this, they have checked the decreased thrombus level and the increased assessed the increased thrombus level and the decreased thrombus length and the increased thrombus length. They have found it's about 29.7% of decreased thrombus level. And the increased thrombus level is 1.3 and the decreased thrombus level is 73.1% and the increased thrombus level is 10%. So it's a decreased thrombus level. There's a clinically significant reduction is there, and so overall it says about 73.1% of measurable decrease level of venous thrombus, tumor thrombus length. And VBT level decrease is 29%, 9.7%. And so it's clinically significant, but and also there's one study that shows cancer specific improved cancer specific survival, and there's a low incident of perioperative complication according to Craven Dindor classification. So in the neoadjuvant group. So, but these studies have some limitation because they are not standardized inclusion criteria. And there are problems with the stage and subtypes and some thrombus level definitions. Some use Mayo's classification, some might use some other classifications, and evaluation of response also a problem because some studies they use MRI to evaluate, some same study they have some ultrasounds and CT also. So some studies they have combinations. Most of they are retrospective trials. And there's a problem with the duration of treatments and dose regime also different. Some use the single agent, some use mixed agents. And other thing is there are limited number of patients are limited these studies. And also they have not measured long-term oncological data in this study, but so because of that, there's a high risk of bias, and also I mean low quality of available evidence to say this studies has good evidence to support the change the guidelines. But they have found one study that is the recently published one. The phase 2 study of neoadjuvant axitinib for reducing the extent of the venous thrombus in the patients with the clear cell RCC. So this is called Maxiva trial. So this trial is a single arm. It's not like a randomized trial, but it's multi-center and it's a phase 2 trial. So that means it's check the effectiveness of the drug. And so they have total have 20 patients with the resectable RCC with the venous thrombus, and then they receive 8 weeks of pre-surgical axitinib. They check the primary endpoint, that is a percentage of VVT improvement by the Mayo level on MRI. And secondary endpoints, they have checked the percentage of changes in the surgical approach. That means they have initially, before giving the axitinib, they assess what is the surgery that patient needs, depending on the VVT level. That's whether it's a minimal access surgery or the open type of surgery with the renal vein control, or whether the patients need IVC, intrahepatic IVC, whether the patients need liver mobilization or suprahepatic IVC control or control above the diaphragm, likewise. And length is measured with the MRI, and also they have assessed the response rate and the surgical mobility also. this is the Mayo level. So level 0 is the in the renal vein. Level 1 is less than 2 centimeters in the IVC. Level 2 is more than 2 centimeters, but below the hepatic veins. If the thrombus is at the level of the hepatic veins or above, but below the diaphragm, it's level 3. If it's going beyond the diaphragm, it's level 4. So in this study, these green ones are patients with the IVC thrombus, and the blue one is the renal vein thrombus, and the white color ones are the non-responders. So according to this study, so Mayo level reduction says patients with IVC venous thrombus, there are 16 patients, so 6 has reduction is the Mayo level. And there are 4 patients with the renal vein thrombus. So only 1 patient showed, and that means a 25% reduction in the myelus. That renal vein tumors, the reduction they have classified according to whether the tumor is beyond the gonadal vein, whether the tumor is in the segmental arteries. Likewise, they have classified it, the reduction of myelus level. But so that's why in this renal vein responders, that Mayo levels is not changing because it's almost 0. But there's a reduction with the this neoadjuvant treatment. So they have assessed the significance of reduction, Simon 2-stage minimax design. So there's a clinically significant, and secondary endpoint they have checked this is the venous tumor thrombus length. So 75% of patients have reduction is in VVT length, and other things they have checked there are 41.1% of patients had the less extensive surgery performed. That means previously if they think that patients need IVC control, then now if they have done it with the milking of the tumor into the renal vein. Likewise, they have assessed the extent of the surgery. So according to this, there's a axitinib has some advantages downstaging in the RCC, and to reduce the extent of the surgery and the mobility of the patient. So, but when you are considering all the trials, so with other trials previously done, I mentioned that retrospective trials. So effect of tyrosine kinase inhibitors on VTT and IVC is variable, and but it may alter the surgical management considerable proportion. And there are small risk of clinical relevant VTT progression. And but according to this meta-analysis, so this existing evidence does not allow for the recommendation for the neoadjuvant treatment. So there's urgent need for prospective randomized trial. Thank you very much.
Thank you, Sanjay. Good presentation. So basically, what your conclusion is that we can do this only in a research setting.
Yes.
So if anyone is interested in doing this, so please record your data and collect your data and present those so all of us will know. Professor Srinath is not in the audience. He has one patient. I think he keep on telling that it is useful because he had one patient who had a large IVC thrombus and he managed to downstage it. and did successful surgery. So he, of course, believes that this is useful. But as Sanjay says, it can happen, but not in all cases. So we are not very sure whether we can just recommend it to every patient. But if there is a patient, particularly, I suppose, suprahepatic levels, it may be worth trying because it is more risky.
Yeah. Yes, sir. Do we have, what are the types of targeted therapy we have in Sri Lanka, sir, other than?
We have pasopanib, sunitinib.
That's all.
That's what I think. But others also from time to time, I think they have. But these even checkpoint inhibitors, they have occasionally, if they want, they can get like sort of individual patient based, but you don't get a regular supply. It's not very reliable.
Sanjay, was there any subgroup analysis of those the tumors who have actually responded? Have they done any anywhere in the literature, like, what sort of histological characterizations or anything which have responded?
There are non-responders. They have there is some I can't remember. There's a Ki69 positive ones. They are the non-responders, and there are some other immunofluorescence analysis.
Yes.
I can't remember actually.
Sanjay said, I think most of the cancers are clear cell, isn't it? Oh,
yeah.
Everyone is clear cell.
Yeah. But the immunohisto profile is little different in certain. I think AI index is
yes.
It says a patient with the clear cells ones also immunofluorescence they have done. Some Ki67s positive ones they also poor responder. There's a progression of venous tumor thrombus, and there are some other immunofluorescence analysis also. There are, I can't remember.
Numbers are also small, no, Nishanta? It's very difficult because of
exactly.
That is a problem.
20, that's a problem.
Yeah, because the other aspect of it that we might be thinking of doing a biopsy and then do the
yeah, that's right.
Immune staining and then selective.
Yeah,
exactly.
Okay, thank you very much.
Okay, thank you very much, sir. And we are coming to the conclusion of today's session. And just before that, let me invite Dr. Nishanta Veerasinghe, who will be moderating the next session with Dr. Taha Mustafa. Our next session will be on the 27th of this month, the Uromet session, the next session. Is Nishanta available?
Yes. Can you hear me?
Yeah, we can hear you, Nishanta.
Sir, Taha said we have actually about 13 topics selected. Now still he's formulating the subtopics and things, but we have managed to get the next big thing. So it will be weekly discussions for 13 different topics. Next week will be the bladder cancer, and the expert panel is Dr. Angavikramarachchi and Manjula Herath from Kandy, and myself and Taha will be moderating. That's the thing at the moment, but the rest of the topics will be displayed soon.
We will allocate the subtopics to different speakers tomorrow. No, Nishanta?
Yes.
I will have a chat with Taha, and we'll just whoever other trainees will get the opportunity.
Yeah.
And we'll try to finish the syllabus during these 12 sessions. That's the plan, no, Nishanta?
Yes, yes.
Yeah.
And I have a small suggestion that regarding this literature discussion.
Yeah.
To minimize the number of slides and just talk only the its the study, the whatever the study's impact and its limitations, and what has it caused to the clinical practice. Otherwise, we can't remember all the things and difficult to boring to listen.
Yeah.
Yeah. So it's,
Yeah,
we have limited time and limited
yeah. But
things. Better to
Nishant,
learn only the.
Yeah.
Sir?
Compared to the lectures that we had, slow sessions, today's ones are far better, I would say.
Yeah. Because in exam setup, we just actually we encountered only the clinical scenario, and then at the end, when we go to that level, they ask the name of the study or just one or two questions, the limitations and impact. That's why I thought.
Yeah, that's right.
Giving more time to the other clinical thing, and then just think mentioning those important aspects of the retreat.
And if any of the trainees or other resource people encounter good articles, please let me know, or Dr. Nishanta or Dr. Taha, so that we can select the articles. Dr. Munipriya was helpful in selecting these two articles in very short notice, but we'll try to get the relevant, important landmark articles as we go on. And I sincerely thank Nishanta, Balagobi, Hillary, and Nishanta Veerasinghe for helping and doing a great job today.
Sir, we didn't ask any question. I don't know whether the trainees have any question to ask.
Yes, sorry. Yes.
Trainees,
We
do you
didn't
have
get
any
the chance?
question to
Yes.
ask from anyone? Okay. So next time when you
I have put a message on the chat box also. So I think the last time we had a very good involvement of the trainees coming with. I mean, this is the platform. You can ask any questions. There are enough number of people who are experts in their fields, and we can have a very good discussion.
Yeah, one point, Dr. Nishant, I want to say is there are some questions we also don't know the answer. The exam also, the last question will be analytical question, which have more marks for you rather than just a recall question about the theory. How will you manage a difficult case? There's no one know the answer. So you will discuss around the topic and thinking about the safety of the patient and available resources. That will give a more marks. So because in a marking scheme, the analytical question will have a more marks. So you have to ask the question, whatever the question, all questions are good questions. So don't worry about it. We also don't know, some answer for some questions.
Yeah, there are many ways to skin a cat, isn't it? And I completely agree with Anuruddha sir. The presentations were excellent, and they were sort of very, very in detail, and they have done a good job. Yeah, I think as Nishanta Veerasinghe said, we will try to include the practice changing sort of seminal papers, the landmark papers, and I think we will make a small format like to make it like into a sort of 1 or 2 slides, just to give the key highlight point of this particular study. And because at the end, in your questions, if somebody asks you to back up your answer with the studies, you need to know what exactly that study is highlighting, and you need to give it in 1 or 2 sentences. So we will try to do it, improve it next time. Yeah, I think Hillary, any more announcements?
Yeah, we have a couple actually. So we are coming to the end. So I'd like to thank the expert panel today, Dr. Anuruddha Gunasekara, Dr. Balasingham Balagobi, and Dr. Nishantalina Pathirana for giving all the trainees very important tips of the trade and how to get through this exam and to improve the knowledge. And and I'd like to also to thank all the attendees, especially the speakers today, Mahendra, Niranga, Chaminda, Dinendra, and Sanjay, for preparing good presentations for today. And so we are looking forward to meet next week. And last but not least, I'd like to invite Dr. Kalana, our Secretary Slaus, to give his ideas on this regard from as the Secretary Slaus. Dr. Kalana.
Yeah, thank you, Hilary. I hope you can hear me.
Yeah, loud and clear.
Yeah, Hilary. I would like to thank the educational committee of Slaus to have this season 2 of Uromet flying, and I heard that this will become a weekly event and every Saturday. So we'll keep our schedules free from 7 o'clock onwards for a brainstorming, reviving session to everybody to catch up things and prepare for this upcoming exam to be scheduled in somewhere in late September or in August, I suppose. So may I thank the CIPLA team for backing up with very short notice, and all the resource persons, and also all the team in the educational committee. So that's all here from the Slaus. So this is our education platform for the all trainees to come together for the exam preparation course.
Thank you very much, Dr. Kalana. And I would like to once again thank everybody for participating today. And I would like to see all of you for the next session. Have a good night.
Good night.
Thank you.